All
Hi.
right. Hi.
Um, this is the first time we're doing it with a video.
First time. First time
First,
with video, first time recording in the midst of a hurricane in
yeah,
Southern California.
because what else would we do?
Yeah, so we took a little bit of a hiatus,
I
but we're
know.
back.
We're back. We're
Oh,
back, and this is the perfect time to be back because you can listen to this episode the next time there's a storm.
hopefully we make it through this one. We'll
Yeah,
see. We'll see.
yeah. So what are we talking about?
All right, so today we are talking about a topic that is near and dear to my heart. Something that we get tons of questions about.
Yeah,
I think a lot of people come into clinic asking if they have this because of things that they've read in terms of symptoms online. And that is PCOS or polycystic ovarian syndrome. So I
yeah,
think this will be a really relevant topic to address.
I agree. I feel like a lot of people as time goes on, I feel like there's more and more like education and awareness about like your menses or your menstrual cycle and what's normal and what's not normal. And I think as a result of just information being more readily available, now people are learning more and more about this. But I think refreshing on this topic and kind of elaborating on it is super helpful.
Yeah.
Yeah.
So I'm just going to kind of briefly give an overview, like a bird's eye view of what we're going to talk about. And then we can jump in.
Okay.
So we'll talk about what exactly is PCOS, how it's diagnosed, um, and then kind of the different ways that it can present, because there's a few different types of what we call phenotypes, or combinations of symptoms that it can present with. We'll talk about what a normal cycle looks like, a normal menstrual cycle, and when it's not normal and when you should seek care from your doctor. We'll kind of talk about some of the ways to manage symptoms of PCOS, because there isn't truly, a cure or a treatment for it. And then we'll briefly just touch on some studies, that talk about some potential new up and coming treatments for PCOS symptoms.
Yeah. Cool. So let's talk about just like overview. So PCOS stands for polycystic ovarian syndrome, and it's one of the most common endocrine disorders found in women. It affects anywhere from 5 to 20% of women of childbearing age. So pretty like big percentage of the population of women.
Mm-hmm.
And there are specific criteria to make this diagnosis. And there's a lot of patients who present to our clinic with a few of these, all of these kind of symptoms that help us figure out whether or not they meet criteria for this diagnosis.
Yeah.
So I know, yeah,
Before we even jump into that, I just also want to mention, kind of like in a more like layman's term, what the understanding of PCOS is. So it's a common cause of irregular periods, of infertility, of metabolic dysfunction, ovulatory dysfunction, and it's thought to be, a a factor of multiple genetic and environmental factors that kind of interact to develop this disorder. And there's actually kind of a lack of understanding about, the pathophysiology, or, the like how this comes about exactly. But there's a couple of theories, and we might touch on those a little bit later. But with that being said, do you want to jump into how it's diagnosed?
yeah. So I'll just go over the criteria for diagnosis. The one that we use is called the Rotterdam criteria, and it's you need to meet two of the three in order to be diagnosed with PCOS. And PCOS is a diagnosis that's made through a combination of clinical assessment and labs and ultrasound. So sometimes the workup for PCOS involves lots of things to finally make the diagnosis, but it could be as easy as a clinical diagnosis. So let's go through what the criteria are. So the first criteria is oligo and or anovulation, meaning irregular periods. Okay, and just to give you an idea, a normal period cycle is every 24 to 38 days. And there's kind of a varying degree of variability depending on where you are in terms of your reproductive age range.
Yeah, so basically, like when you first start menstruating, your periods can be irregular and that can be normal. And then as you get into kind of your middle age, they should be pretty regular. And then as you get closer to menopause, they kind of get irregular and longer again.
Yeah. But just the most important thing is like there's lots of variation in what's considered regular. So just keep in mind like there may be changes in your period. And if you're concerned about it, seeing a provider is worth it. But it may be that it's still within the scope of what we would consider normal.
Yeah. And I think part of that confusion comes from like everyone hears like 28-day cycle. Even the birth control pills are like formulated around a 28-day cycle. And so it's easy to think, oh, if I'm, deviating from a 28-day cycle, something is off.
Wrong,
But
yeah.
even, up to a 32-day cycle can be normal.
Mm-hmm.
Or, having less than a 28-day cycle can also be normal.
Exactly.
Not necessarily is.
Yeah. So I think it's worth, like if you're concerned about it, if you see an abrupt change in your own cycle, especially if you're somebody who's tracking your cycle pretty regularly and you see a change, getting evaluated, I think is worth it, with a provider. So that's the first of the three of the criteria. The second one is polycystic ovaries on ultrasound. Third criteria is clinical and or biochemical signs of hyperandrogenism. So irregular periods, polycystic ovaries on ultrasound, and signs of hyperandrogenism. So those are the three of the Rotterdam criteria.
Mm-hmm. Yeah. Yeah. So for the polycystic ovaries, so what that really means is that, every month when we're ovulating, our ovaries are creating follicles or small cysts. And one of those cysts is kind of going to, present itself as the most dominant cyst, the one that responds most to the hormones that are being secreted. And that's the one that you'll have ovulation of an egg from. But in PCOS, there is an increase in something called luteinizing hormone, and that causes an increase in the androgens, which is basically, some people can think of it as kind of like the male hormone in some ways, from certain cells in the ovaries, and that impairs the ovaries' ability to respond normally in terms of its development of follicles. And so you never develop this single dominant follicle, and instead what ends up happening is you have multiple small follicles, of which none ever end up ovulating, and that's what causes the lack of ovulation in PCOS. And with that comes, the appearance of these polycystic ovaries, where this disorder gets its name from. So getting into like the nitty-gritty details, what that looks like on ultrasound is in each ovary you can see 12 or more follicles that usually measure 2 to 9 millimeters in diameter. Or if you're not seeing necessarily a higher number of follicles in each ovary, you can see a higher volume of each ovary. So an abnormal volume would be considered greater than 10 milliliters.
Yeah, and these ovaries tend to be larger. So,
I was just going to say that can lead to kind of the symptoms of bloating and some pelvic discomfort.
Yeah. And there are ways to look at or measure the ovary that will give you the diagnosis. And I think I know for sure sometimes, like when I look at an ultrasound report, they may not necessarily give you this volume. So this is something that we have to kind of look and dig for, because they may not comment on this. But the ovaries, if they're polycystic, usually the reports of the radiologist will comment on that.
Yeah.
And then the other thing is, I was going to say, sometimes you have an ultrasound done and they mention that you have a cyst. And most of the time, if you don't have PCOS, the cyst that they're talking about is that cyst that you mentioned
Yeah.
earlier, that dominant, and that's normal.
Yeah, definitely.
So we're really looking for multiple cysts on these ovaries, something like 12 or more.
Yeah, and it actually has this name for like the classic appearance is string of pearls. So that's kind of like pathognomonic for this, for PCOS.
Yeah, meaning like there's lots of little cysts around the like periphery of the ovaries.
Yeah.
And then the last symptom we were talking about was clinical or biochemical evidence of hyperandrogenism. So, like you had said, in patients who have PCOS, they have higher levels of circulating androgen. One of the lab tests that we do to determine that is a testosterone level. And testosterone, like you said, is the classically like the male hormone, if you will. Women also have circulating testosterone. It's just not as high as the level of testosterone that men have.
Right.
And when we see patients with PCOS, sometimes we'll do blood work if we're doing this part of this evaluation, and we'll see elevated levels of testosterone, which is could potentially be one of the ways that patients meet criteria for PCOS by the Rotterdam criteria. The other way that hyperandrogenism can manifest is with some like clinical signs like male pattern hair growth. So a lot of patients will complain of a lot of facial hair or chest hair or abdominal hair. Or other signs or symptoms like clitoromegaly, so enlarged clitoris, is some of the most kind of common presentations of hyperandrogenism that I've seen.
Would you say acne also falls into that category?
And acne, for sure.
Yeah. And then I want to kind of tie that back into some of the other findings of PCOS too. So those higher, I guess back into like the metabolic part. So there is a higher level of insulin as well in the blood of people who have PCOS because of this underlying resistance to insulin. And so instead of that insulin being inside your cells, it's kind of circulating in your blood. And that actually reduces the amount of this circulating thing in your blood called sex hormone binding globulin. And basically what that does is it kind of, in a sense, inactivates certain circulating levels of testosterone in your blood as long as it's bound to that. And when there's less of that, that leads to increased circulating levels of active testosterone in your blood. And so that's how you kind of get those symptoms of the, hair growth and acne and things related to increased testosterone.
Yeah. So to recap, high insulin leads to sex hormone binding globulin, which is the thing that would stop testosterone from being active. But because there's not enough of it, there's more active circulating testosterone, which leads to all these signs and symptoms.
Exactly. Yeah. Okay, so maybe we can jump into kind of the ways that PCOS can present clinically, meaning like what kind of signs or symptoms can people have, because there's actually 4 what we call phenotypes or 4 ways that it can present, 4 different combinations of these findings of PCOS. So I guess traditionally, PCOS has kind of been attributed to this phenotype of an overweight woman with acne, excessive hair growth. But more recent information has actually shown that, women can be lean. You don't have to be overweight to have PCOS. So you want to jump into the 4 phenotypes?
Yeah. Yeah. And I think it's good that now we're talking about phenotypes because I think because there was such a specific presentation of PCOS that we kind of all studied in the past. We were underdiagnosing, I think, PCOS.
Yeah.
But now I think because we know that there's more than one way that patients present, that we are like actually accurately diagnosing patients with PCOS. So we're able to help them.
Yeah.
So the four phenotypes, they're listed as A, B, C, and D. And they're just a combination of what are the presenting features or symptoms of the patients from the Rotterdam criteria that we mentioned earlier. So, for example, phenotype A is known as full PCOS, and they have all three of the Rotterdam criteria. So they have hyperandrogenism, they have oligo or anovulation, meaning irregular periods, and they have polycystic ovaries seen on ultrasound. Phenotype B is classic PCOS. So these patients have hyperandrogenism and irregular periods. Phenotype C, known as ovulatory PCOS, have hyperandrogenism and polycystic ovaries seen on ultrasound. And phenotype D, known as the non-hyperandrogenic phenotype, just has the oligoanovulation or the irregular periods and the polycystic ovaries. So they don't really have any of the hyperandrogenism features.
Yeah.
So
And I think you make a really good point, because I think a lot of people would go to their primary care doctor, even their OBGYN, and say, like, I have irregular periods and, I feel like there's excessive hair growth. But if they didn't have the polycystic ovaries on ultrasound, it was kind of thrown out. It's like, well, you don't have PCOS. And that kind of is such a disservice, because it is a missed opportunity to help someone with those symptoms, and all of the things that come along with PCOS that we'll, touch on next, like metabolic syndrome or infertility issues.
Yeah.
So.
Yep. Yeah. I've definitely had patients who were diagnosed purely clinically because of those symptoms that they presented with.
Yeah.
So you had mentioned that there were other kind of syndromes or conditions that were associated with PCOS, like metabolic syndrome. So I don't know if you want to touch on what metabolic syndrome is, but basically it's a constellation of multiple kind of conditions that lead to other issues. So there's 5 diagnostic features, and to meet criteria for metabolic syndrome, you only need 3 of 5. So those 5 are insulin resistance, central obesity, so like abdominal obesity, hypertriglycerides, so high triglycerides, elevated cholesterol, and high blood pressure. So if you have 3 of those 5, you technically meet criteria for metabolic syndrome. And one of the ones for sure that a lot of patients with PCOS will have is the insulin resistance.
Can we talk about that for a second too? I think, so insulin resistance, like, what exactly does that mean, and how do you diagnose it, and why do we care?
Yeah. So insulin resistance means that your body is creating or producing insulin at a higher rate than maybe somebody who doesn't have PCOS is, which makes it harder to kind of regulate your blood glucose. So sometimes patients who have PCOS are pre-diabetic or diabetic. And so that's important to know, because diabetes is something you want to manage separately or in addition to patients who have PCOS for other reasons. Diabetes is a whole other kind of diagnosis. And so you want to make sure that if you have a patient with PCOS, you screen for diabetes.
So insulin resistance can be seen kind of as a precursor even to diabetes. So like you're saying, like someone who's pre-diabetic has kind of a low-lying insulin resistance, meaning their cells aren't able to like utilize the glucose in your blood as well. And so you just have this high level of circulating glucose, which over time, can lead to diabetes and all of the other sequelae that go along with that. So definitely something, if you get diagnosed with PCOS, your doctor should also be screening you for diabetes and helping you develop, a meal and exercise plan that's going to reduce your risk of developing insulin resistance and diabetes in the future.
Yeah, and something that I found like while we were like prepping for the episode was there's a lot of new data and like kind of in the fitness and wellness world, there are people trying to come up with like tailored diets for patients who have insulin resistance, who might be pre-diabetic, because uh, this is like one of the ways that we recommend patients manage PCOS is with like lifestyle modifications, including kind of dietary modifications. So there is, if you Google, you'll find like a PCOS diet, and so it's interesting.
Yeah. And just, okay, one final little plug. This is just kind of my personal little thing. But I think in, Western medicine, we're really good at treating once there's a problem. We're not so good at preventing. And so I think diet and exercise are so key in preventing, this insulin resistance and metabolic syndrome from forming, that if you feel like your physician is not giving you the support that you need on the diet and exercise front, because to be honest, we are not truly that well trained in that, and there's really not time in the grand scheme of things of our appointments with patients. But you can request to be referred to a nutritionist. You can seek out your own type personal trainer, or someone to help you with the exercise outside of medicine, because I think that is key. And don't depend on your physician, I think, to provide that for you, because I don't think we're well equipped for it, but don't underestimate the importance of it either.
Yeah. I think like the approach to PCOS, it should be like multifactorial. It's not just medication, it's like lifestyle choices, dietary choices, level of physical activity. It's like it has to be kind of all these things in order to really manage PCOS. And PCOS, there is no cure for PCOS. So what we do our very best is to try and manage the symptoms to minimize the impact that PCOS has in your life.
Yeah.
And so we'll talk about treatment now, because I think, we've gone through all the other things, and this is what most people want to know anyway. They want to know, if I have PCOS, or if I think I have PCOS, what should I start doing, or how should I approach my treatment? So there's lots of symptoms or kind of factors that we take into account when we're talking about treatment for patients. And if we go back, let's go back to the Rotterdam criteria. So one of the things that is one of the Rotterdam criteria is irregular periods. So, and we can talk about what the over time, what the end result can be if patients who have PCOS end up going undiagnosed and untreated for years and years and years in the setting of irregular periods. So number one, because patients who have PCOS tend to form ovarian cysts pretty frequently and regularly, sometimes these cysts can grow and can lead to pain, discomfort, bloating, but may ultimately get to a point where they require surgical management. So regulating your periods is one of the things that helps prevent that from happening. The other thing is because there are irregular periods during during that time of anovulation or no periods, there can be an accumulation of the inside of the uterus, which we call the endometrium. And over time, if that does accumulate, sometimes the cells of that inside lining, that tissue that would otherwise kind of come out as a period, tends to become irregular or abnormal, or sometimes even precancerous or cancerous. So to prevent that from happening, and to prevent kind of irregular cysts from growing and forming, one of the things that we offer patients is hormonal contraception as management for these symptoms.
Mm-hmm.
So, that's one of the things we counsel patients on when we know they've been diagnosed with PCOS or we suspect they have PCOS, to prevent that kind of like those problems from happening down the road.
Yeah. And one thing to note also is that, that can be something that you start initially to regulate your menses and to make sure that you're not building up that abnormal lining that can lead to uterine cancer eventually. But also, even a modest amount of weight loss, like 5 to 10% of your body weight, can often restore normal ovulatory cycles. So if you're, the kind of person who really doesn't want to be on hormonal birth control and you want to try and find a more natural way to restore your body's ovulation, that can be another, thing that you try as well. And you can just get on the birth control initially so that, you're at least creating that regulation of your menses as you're working on, the weight aspect of it. But that can also be, an option.
Yeah. I think that's why I was like, I feel like it's multifaceted treatment
Mm-hmm.
that manages PCOS the best. Because you're right,
Yeah.
weight management may be super beneficial, but may not be the complete treatment, and
Mm-hmm.
the hormonal contraception may be part of it, but may not resolve the problem altogether. So,
Yeah.
um, that's for that one first kind of Rotterdam criteria point. The second one was or the third one actually is the hyperandrogenism, or the side effects of hyperandrogenism. So, how do you normally treat patients who are presenting with these symptoms?
Yeah. So there's a couple ways. I mean, one is obviously, shaving, waxing is one method, but it's something that has to be repeated frequently. But starting an oral contraceptive with estrogen and progesterone can actually decrease your hair growth and treat that aspect by decreasing the amount of circulating androgens. So, that's one thing that I'll recommend. And then there's also medications that actually target androgens and target, a decrease in the circulating androgen levels, such as spironolactone. So that's another medication that you can take in addition to an oral contraceptive to reduce hirsutism, or the hair growth.
Yeah, and I have a lot of patients who come in who have acne, and there are some birth control pills that specifically are actually FDA approved for acne management, in addition to being hormonal contraception.
Mhm.
So, for patients with PCOS who are struggling with these two things, I usually will kind of lean towards those medications.
Yeah. It can be a good way to target, a lot of symptoms of PCOS
Yeah,
initially.
yeah, um,
Yeah. And then I think the last thing that we haven't touched on is just the underlying metabolic disorders, and each of those will be treated a little bit differently. So, if there's prediabetes, metformin is an option. If there's actual, fulminant diabetes, then insulin may be necessary. And then obviously, triglycerides and cholesterol can be treated separately as well through diet and medication.
yeah, yeah. Once the diagnosis for PCOS is made, usually I think what ends up happening is all these other things start to be investigated further, right?
Mm-hmm.
Usually the initial evaluation for PCOS doesn't include looking at cholesterol levels or
Right.
triglyceride levels. But once we make the diagnosis of PCOS, now we're a little more invested in figuring out whether or not these other things are also happening.
Yeah.
So, and once those things are investigated, and if there's a diagnosis that's made, I usually will manage that as it comes.
Yeah. And then I think also, for women who are wanting to get pregnant, there's a little caveat in terms of the management too. So, what if you had a woman who is coming to you who, was diagnosed with PCOS, irregular periods, but wanting to get pregnant? how do you usually manage the irregular periods?
Yeah, so a lot of the time, and I remember we talked about this when there's a patient who's diagnosed with PCOS, usually the first thing we do is we want to put them into one of two categories. Are they actively trying to seek pregnancy or not? If the answer is no, then we go down the kind of treatment path that we just described with hormonal contraception, and all these other kind of things. If they're actively trying to get pregnant, we take out a big component of treatment, which is hormonal contraception. But there are other things that can continue to be part of treatment to try and get them to manage their symptoms, like you had mentioned earlier, a 5 to 10% weight loss, decrease in BMI or decrease in body weight to try and get them to a point where they may have regular cycles. If they're, now let's say they have been diagnosed with PCOS, they make the changes in their lifestyle. Let's say they get to a point where they're now having regular periods, and they're still unable to achieve fertility. At this point, now we're talking about like considering ovulation induction medications, basically to try and get these patients to ovulate. And there's several kinds of regimens for patients with PCOS to try and get them to achieve this goal. But I think, at that point, I will talk to like reproductive endocrinology to try and figure out what's the best regimen for this patient.
Yeah.
Yeah.
Same. Yeah.
Yeah.
Okay. Well, I think we covered the basics.
Yeah.
I think the last thing that we had to talk about was just some recent research. So there was an article in the Journal of Reproductive Biology and Endocrinology in January of this year, 2023, that was looking at inositol. I always say this as a potentially effective and safe treatment for PCOS. And so this was a systematic review and a meta-analysis of randomized controlled trials. And basically, the background of this is that metformin has classically been the gold standard for use in PCOS as an insulin sensitizer. But it has common, side effects like upset stomach, or what we call gastrointestinal side effects. And so they wanted to look at inositols as a potential alternative for metformin in treating PCOS. And so kind of looked through 26 randomized controlled trials that included data from a total of 1,691 patients. And the basic conclusion was that this inositol does work. It's effective and safe for the treatment of PCOS. It showed non-inferiority in most outcomes compared to the gold standard treatment, which was metformin. And it showed that they positively influence the menstrual cycle regularity, carbohydrate metabolism, as well as clinical and laboratory symptoms of hyperandrogenism, so that elevated testosterone level. So I think that's exciting news, because in general, there hasn't been a lot of movement necessarily in terms of, treatment for PCOS, and this is potentially something new.
Yeah. Yeah. Outside of hormonal contraception, specifically combined oral contraception, there hasn't been like a whole lot of additional kind of management options. Metformin specifically was being used or is used occasionally as an insulin sensitizer. And I think there's a lot of debate about whether or not it's indicated or necessary or recommended. But I think myo-inositol is a good alternative, which seems to have a low side effect profile that can potentially kind of help with insulin resistance.
Yeah. And you don't need a prescription for this. It's like an over-the-counter supplement. We kind of did some market. We can't necessarily endorse any specific supplement because we haven't done our own studies on them, but they're out there. And I think, supplements, as long as you can find a reputable brand, they're worth trying.
Yeah. And you ask your doctor. I would say it's something that's worth investigating, as a patient for your own kind of like, education and like health advocacy.
But also exciting announcement. We're starting a YouTube channel where we're going to post the videos of all of our upcoming podcasts. So check us out there.
Yeah. I think what I would want to know, like if anybody watches this, do you think that this is a better medium than just audio podcasts? That's what I want to know.
That's true. Yeah.
Right.
Like, do you actually want to see our faces, or would you rather just hear the audio? It's fine. We won't be offended either way. Just let us know.
Yeah. So we might like send out a poll.
Okay.
Cool.
All right. Well, as always, send us your questions on Instagram, email girlmeetsgyn@gmail.com, or you can leave them on our YouTube channel as comments.
Yeah.
We're happy to answer anything, and we look forward to the next episode.
Yeah, and it'll give us some ideas also about upcoming episodes potentially.
Definitely.
If you're in Southern California, stay safe. And we will see you next time.
Bye.
Bye.